EP newbies, on-the-job trained people, say the hardest part is knowing what, I guess, intracardiac changes everyone just saw. How did you learn?
Watching them over and over and over again. Repetition.
Yeah,
Repetition.
Is there really anything you can do like outside of cases?
No.
Or just you have to get involved in the case?
You have to do the case. You have to see the intracardiacs. You have to watch the pacing protocols. You have to watch the screen.
It has like a full disclosure. You can go back and replay, right? Or no?
The recording?
Yeah.
If they're recording, which they should be recording
The whole
anytime
thing.
they're pacing, yeah, you can go back. And that's the problem. A lot of people who are learning, they're not the one doing.
Mm-hmm.
They're like standing, right? So they're observing. And so this person is already trained and they're clicking away. Now I do this because I did the tactile, not the touch screen. But they're clicking away and then we see it and we're like, okay, yeah, antegrade, click.
Move
All right,
on.
they're there. And they're like, but I don't understand, and we keep going unless we have time to stop and explain it and show it. But in the downtime between cases, if you have that, my lab that I started in we didn't have that. Literally our next patient was in the hallway and we still got to get this one out. But you can do that in the downtime and you can replay all of the recordings. You can reopen the study, run, and look at that. What I tell people online too is for intracardiacs, the easiest way is to focus on what you're supposed to not see.
Where the change will happen.
Right. So if you're looking for retrograde and we're pacing in the V, don't stare at the V. You start by pacing the V. Make sure you're capturing. Once you see that you're capturing, you take your eyes off of the RVA catheter because we don't care about that.
Yeah.
We're pacing from there. What we're going to miss is the A. So focus on your CS if you have one or your high right if you don't have a CS. And you look at that, and I'm 100% here to tell you, if you stare at that one going straight across, you can see this. This. You see that big hole there? That's where your block is.
Yeah.
Focus. Don't try. That was my mistake. I was like, there's too many lines. I can't. What am I supposed to be looking at? How did you see that? You can't look at all of the intracardiacs. You have to focus on one.
Do you even do that when you're experienced, or when you're experienced you have more peripheral vision?
Now that I'm experienced, I can look at everything. And I immediately see when it goes rolling by.
Yeah.
When you're learning, you can't look at every single intracardiac. You've got to look and focus only on one.
Yeah.
And so I tell my people that I'm training in the lab or however I'm training them, you look at what you're going to miss. Don't look at anything else. The only time you want to look is when you first start pacing, because if you're not capturing, then we can't go any further.
Yeah.
Am I capturing? If the answer is yes, take your eyes off of that one and go to where you are going to miss.
Because personally, I struggle the most with, of course, accessory pathways, but even like flutter sometimes, post-ablation stuff and changing of direction and all of that. Is for those things, is that something you have to look at everything? Because like refractory periods and the early on protocols, there is only one thing happening on one line. It's not happening everywhere, unless you really screw something up, or they go into an AFib or something. Yeah, but for the other types of things and ablations, do I kind of have to have more of a directionality bird's eye view? Because I feel like not one thing is happening.
Yeah, you need to be looking at the whole picture.
Yeah, I have noticed there's change in conduction. There is kind of a global change more than a pinpointed change, at least for the ones that I've looked at. I haven't looked at VTs or any of that yet.
Yeah.
That's not on my radar.
Yeah.
That sounds more pinpoint, but.
Yeah, you have to look at the whole picture.
Yeah.
When you're doing pacing protocols, you're specifically looking for that one thing. But when you're in real time, yeah, you're looking at all of it.
Yeah.
Because, for example, you could be looking at intracardiacs and they all look completely normal. But if you look at your surface, you could have an ST segment elevation. It's not going to show in your intracardiacs.
Yeah.
So, and why do I use that example? Because that is one example that happened to me. And it was when I was fairly new, and it's back when we did AFib ablations, and we actually ablated inside the pulmonary veins, inside, with a 4 millimeter tip ablation catheter. So we would take a venogram of each pulmonary vein to prove that it was patent. then we would ablate it, and then we would do a venogram post to make sure we didn't stenosis it. And one of the things,
right heart cath patient with pulmonary vein stenosis post ablation.
One of the things that we could do is cause that, and they could ST elevate. And I was just like, I'm staring at the screen. I'm fairly new at monitoring. I don't know what's wrong. I just know that this doesn't look like it used to. Immediately said something. Hey, could you take a look at that? Because something's different. I just don't know what it is. And he's, oh shit, oh my God. Yeah. So it was, and I was like, that was
important.
Oh, that was, yay. I still don't know what the problem is. But I knew that what I had been watching had changed. And I didn't
whether
know
that was a good thing or a bad thing.
Yeah. And yeah, I might sound stupid. Sure enough. But guess what? I was new, and I just knew something had changed. And so I'm willing to sound stupid. I just said, can you take a look at that? Because something changed and I don't know what. And then he immediately started giving orders, and I was like, oh, I'm glad I said something. But I didn't know at that time. And then later, after everything had calmed down, I'm like, what was that? And, he explained, and I'm like, oh. And he's like, yeah, anytime you see something and you're not sure, you say
that's a good way to say it. To say, yeah, take a look at it, or something has changed, because you're not, if you did call it out wrong and they're not actually looking
for that,
and it isn't something important, but you called it wrong, then they're just kind of ignoring you, versus making them have to look at it and figure out what it is.
I want you to take a look at it, because I'm new.
Yeah.
But what I'm telling you is something changed.
Yeah.
And I don't know why.
I think that's a good way of approaching it without really ensuing panic.
Right. So for me, gave me some confidence. You may not know what's happening, but you know it's different. You know it's not normal. You know it's not what it has been. So you speak up. Yeah. And when I did that, it gave me confidence to speak up the next time I saw something, and the next time. And then when I finally started learning more, I had that confidence.
Because what if it is that one time?
Right.
So, and then it's worth it.
Yeah.
Can you pick up a perf on, besides just going based off impedance, on mapping, or not really?
On mapping, no.
No, and not on the intracardiacs, because it's just
not on intracardiacs.
Electrical conduction.
So the first thing,
hemodynamics, all you have is non-invasive cuff.
Right. So when you're looking, if you have a perf, the first thing that you will start to see is blood pressure. Mm-hmm. You'll have a dramatic drop in blood pressure. They'll say, recycle the BP. You'll recycle, but then they can step on fluoro. If they suspect that, then that's the first thing they're going to do. Then they'll call for stat echo. Yeah. Then we'll be recycling the BP, blah, blah, blah. If you're doing a transeptal puncture, you already have the intracardiac echo ultrasound in there, and so they can kind of move it around and take a look. They will typically still want to have an echo to confirm before we do pericardiocentesis. Primary issues are, of course, you're going to see the blood pressure drop, which is why if you're using anesthesia, they need to know that they cannot medicate a drop in blood pressure without telling somebody. Yeah. Because we can
even if it seems like
we
it's
can
from
burn
sedation.
through. Yes, that's not something that they should be treating without telling the physician. Yeah. Because it's something that could be huge detriment, and if they've been treating it and not saying anything, by that time the patient's lost so much blood, then it's hard to recover.
Yeah, and that's part of, again, being comfortable working with other people in the room and telling them what's important for you, because they might not, it might be their first day.
A facility where they don't have dedicated, because it came to the point, at least when I worked down here, when we were using anesthesia for AFib cases, they tried to send the same CRNAs so that they kind of knew our flow and knew those things. But it's not like that, because in Tennessee we use them very rarely, because we use deep sedation, but very rarely we would have them, and it was whoever you got. Any control over that.
So you have to educate a little bit.
Yes.
And you're not telling them they can't do their job. It's more like, hey, here.
That's how they receive it.
Yeah. And here,
that's how anesthesia receives it.
This is your role, and the most impact you can have in here is letting me know if blah 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 happens.
If you have a sudden drop in blood pressure.
Like, yeah, working in the OR with Abiomed was the biggest difference for me, because it's very don't speak unless spoken to, at least the ORs that I went into, and I wasn't used to that. Like, I was used to communicating my needs, what are your needs, like what are the expectations, when working with a new team, and to be received that way, I was like, I never wanted to say anything.
The standard.
Yeah, I never wanted to say anything. And anesthesia, if they mostly work in the OR, that's the environment they're used to. Like, nobody talks, everybody does their job, and we move on.
That's what they're used to.
Yeah.
But that's not how it works in EP.
You balance speed and efficiency with safety in high stakes procedures.
A lot of it is muscle memory, but you also have to know where is your emergency equipment. What do we do? What's first? What's second? Like prioritization. You need to be confident enough to know where your equipment is, what you need for what complication, and be able to turn on a dime. Not going to be competent if you haven't sought those things out, because remember, complications don't happen that often.
Yeah.
So you have to kind of mentally go through those things. And sometimes I would do it when I was in cases. Not that I'm like wishing anything, but I would be like, okay, well, you know, we're kind of hanging out here for a minute. What would happen if? And I would think through that process. Okay, well, we would call for, if I think we had a burn through while we were ablating, I would call for a SAGO. We would recycle the BP. We would turn up the fluids, let them run. We would have somebody go ahead and pull the pericardial centesis tray. If there wasn't somebody currently scrubbed in with the physician and all this stuff started happening, somebody needs to get scrubbed in, get their lead on, and because they need assistance to do pericardial centesis. So during normal cases when there weren't complications, I would think of those things.
Hypothesize, yeah. And I think as a preceptor, that's a good thing to ask your trainee. Like, okay, if this happened
now, what would you do?
What would you do? You don't want your first time thinking about it to be when it happens.
Like a plan.
Yeah.
You don't wait till something happens to be like, oh, what are we going to do? Make a plan, and that way when it does happen, because complications will happen. Fortunately, they don't happen very often, but when they do, they are going to happen, and you have to know where your stuff is and what you're going to do.
The first time we had a perf in the lab, I know to call echo. What the hell is the echo number? Where is the echo number on this 10,000 page thing of numbers that we have?
In an EP lab, the echo department number should be up on the
You have to know where okay, I need the pericarditis, I need this. Where is all of it? I don't know where
your emergency equipment is at all times, and you should know pertinent phone numbers.
Because you're going to freeze a little bit the first time.
Sometimes not even the first time, it's the 50th time. Yeah. But you need to kind of rehearse it in your mind sometimes, because they don't happen all the time.
Yeah. For the worst, hope for the best.
Yes. You never want to get in such a hurry that you skip steps.
Yeah.
That's where mistakes are made. So you still need to be safe and effective and timely, but don't cut corners. That's where stuff starts to really spiral.
Yeah. And if you do catch yourself doing that, like stop and rethink your process.
Stop and breathe.
Yeah. Because I've had scenarios like that where then I made a mistake and I'm like, how did that just happen? And I was like, okay, I skipped this because I was rushing, and the 2 seconds added to double check your stuff is better than
4 minutes,
15 minutes lost in a code or to fix something. Yeah, it's worth it. You might feel like you're saving time, but one day you're not saving time.
It will bite you most of the time.
Yeah. Our contributor in the book, you can read all about Shawna, because is the process what you expected? You haven't done anything like this before. I know what my experience was the first time.
Not to this depth. Yeah.
Well, yeah, and I feel like curating courses is kind of similar. Like there's a lot of overlaps, there's a lot of research you have to do and verifying what you know and all of that. Do you learn anything through it?
Oh yeah. The process is very tedious still, even if you know, because as we're going through and we're adding or editing, you're looking at it through a very fine lens, because you don't want there to be typos. You don't want there to be a mistaken way something is phrased, because then they may misunderstand it, or they may misinterpret it. Or I think, and I said that to you a lot, I think this would be better if you said like this or that, because people might assume it means this. So you're looking at it through such a magnified lens, because everything needs to be exact. I mean, yes, we're human beings and we're not perfect, but you want it to be as rigid, perfect, accurate as possible. So going through that's tedious work.
Yeah.
Like, even if you know this stuff. And then, of course, there's some things that, I mean, I haven't worked clinically in a lab in a while, and so I was like, I will defer to Aaron and Matthew on this, because this is not how we did it, so I don't even want to speak to it. So I learned some of the newer things, and I've learned some of that on the social media too. Like, we used to not be able to use the quad on the temp pacer, for example. That was not an option. You couldn't do it. And Aaron's like, we have adapters now. And I'm like, wow. It only took them how many years to do that? But yeah, I mean, so like, I've learned some, through social media too, things that have changed. So I learned some new, and of course, PFA was not a thing.
I mean, it wasn't a thing like a year ago.
It wasn't a thing. And
everybody's learning it for the first time.
Yeah. So the spasm and
Coronary
people giving
spasm.
nitro with it, I would have never known that. Even though if you know a lot, it's still a lot of work.
Well, I feel like, and that's EP in general, Aaron and Matthew even being active in it, we're like, check on this, or look at this, or see how this is done other places, because this is how we do it.
Right.
Matthew works with physicians that are very out of the box, and he'd be like, we do it like this, but I know that's like way off label, so please go figure out the textbook way to do it. And I was like, okay, like, I'll put this as a, hey, FYI, like, you could do this, but here are, some other options. And I mean, it was hard for me. Like, I had a great team, and I'm glad, because you are my verification, and EP is so limited in resourcing. And even when you look up stuff online, I've found more on the EP side than the cath side. What you find published are unique, once in a lifetime cases. They're not everyday monotonous cases. Like, they love talking about this one unique thing that happened, or this thing that we did, and eventually maybe it'll be some type of standard practice, but that's not what most people are spending their time writing on and talking about.
Correct.
Is, how do you measure this interval?
That's so
If
like
you
basic.
Google that,
We're
you
not
will
gonna
not
talk
find
about
it.
that. Right.
Yeah.
Same thing at HRS. They're presenting these
Like,
super
what's that
complex cases. And I'm like, this is amazing. But wow, it took me a minute to get back in that mind frame of, okay, yes. Okay.
And both of you would tell me, you can tune out now. I'm
Yeah.
like, okay, thanks.
Yeah. Because this, I'm
I was
like,
following.
this is super complex stuff. Or having two arrhythmias simultaneously, and one's coming from the left side, one's coming from the right side, or one's epicardial, and that's why we've burned the what out of it, and it's still there. There's so many things that are so different with EP, which is why I'm like, that people just don't know the pure depth of what they're getting into. And that's why there's no concrete, there's no black and white, because there are these once in a lifetime cases, or this one patient has a congenital defect and they have this XYZ. And sometimes in ablations we fix one arrhythmia, but then because of the scar they get a whole new one, and then they come back and they're like, but you said you fixed me last time. And they don't understand.
We did fix
that,
Yeah.
But because we fixed that, now you have a scar, and now you have an arrhythmia going around the scar that we created, that we had to create in order to fix it. So there's so many things. But yes, still learned. Yeah.
I mean, even for how long I've been doing cath, and even I feel like when you're not in the lab, you have to do 10 times the amount of research to make sure and understand than when you're doing it in person and learn it, and then are doing all of that after the fact. And even in cath now, I learn stuff all of the time, because I've never, even when we were teaching against students who don't know anything, and you do teach them to a certain level, but there's a certain level you can't go beyond, because that's going to be way too much for them, and they're not there yet.
Right.
But here you have to incorporate both.
Everything.
Right? Both for newbies and both for something value added.
Yes, because you have people brand new starting out, but then you also have people who are like, I've been in the lab and I understand all that foundational basic stuff, But I want to know, how do we differential diagnose and say that this is a pathway versus ABNRT? So
like,
you have to be
great.
able, you have to be able to do.
Let me figure out how to
of that.
present that without making the newbies cry.
These are gonna cry. That's just part of it.
Because I mean,
I just thought, and that's the thing. What you experienced is what they experienced.
yeah.
But I thought I just understood that, and now you're telling me this, and I'm like, yeah, because you weren't ready for that before. Now you're ready for it, and now
I'm like,
you're
well, this
crying
really thinks my whole way of
because you're like, I
presenting
thought
this.
I had this, and I thought I understood, and I'm like, but you did, but now this is.
Now we're moving forward.
Yes.
And I'm like, but then that changes what I said about this in the beginning because there's an exception to the rule.
That's why we use words like most often,
Historically.
typically, historically, normally.
So how do you feel from the, I mean, because you've been in both, from the perspective of someone who is new, how should they utilize it based on the way that it's written? And then for an experienced person, because there are people who are just supporting, and I really appreciate it, or are preceptors and want to get it.
Mm-hmm.
How should each of those people use it?
If I was a brand new person, if I was just going in, I would start right here. Welcome to the EP lab.
Do you think it's in an order that
You,
is purposeful?
yes, because unless you've been in a lab, you don't know this. I didn't know X-ray.
Yeah.
I mean, all I knew about X-ray when I started was chest X-rays. A therapist. I looked at chest X-rays every day. ICU patients had chest X-rays every day. We're looking at the diffusion. Are they whited out? Do they have ARDS? Is it getting any better? Do they have ventilated associated pneumonia? Like, I knew chest X-ray. That was it. I didn't know about the effects of radiation and how it affects the cell and the inverse square law. And the more you're away from it, the more it exponentially drops off. I didn't know what properly fitted lead should be like. I didn't know when I started to wear lead line goggles. Nobody told me. So yeah, you've got to start here. If you're brand new, you've got to start with the basics. And I know to some people, when they open this up, they're like, oh my goodness, what is this? I've been here for a year. Okay, great. If you've been here for a year, then you need to move on. But you know what? You may find stuff here that you know that you did, but you didn't know why or what it was called.
Yeah.
So there's still something that you can learn from it, even if you've been in the lab a year in these basic things. Like one of the things I told you were like, I didn't know that S could stand for stimulus.
Yeah. Well, someone
I'm like,
asked me, what is, I had a cath person read it, and she asked me, two different people. My editor asked me, who works in cath IR, and then Nikki asked me, does S1 stand for something? I was like, I don't know. I had to go, I had to go in the instruction manual for a micropace, I think. That was the only one that had like a definition for the acronym. And I was like, I don't want to call it something and it's not actually called that. I was like, yeah, I guess it does stand for something.
Yeah, when I sent
question.
When I sent you that, you were like, I never even thought about the S standing for something. So you may find out something that you knew or you did or you used it, but you didn't know why you called it that or whatever. So there's still things that you can learn from here. Also, frames per second, all of that. I learned that in the lab. I had no idea that you could change the frames per second, and by changing that, you change the quality of the image, you change the dose of radiation. I had no idea. I knew what fluorosave did because I got my butt chewed numerous times about not hitting it fast enough. If you've been in the lab a while and maybe now you're doing ablations, okay, so maybe like you feel comfortable doing pacing protocols and you can see refractory periods and blocks and all of that. You can even tell, okay, differential diagnosis. Okay, I get why we do these certain things, but I don't understand how ABNRT is different from AVRT.
I feel like a lot of people struggle with AVRT.
They do.
I mean, I did. It brought me to tears many times.
It's the number one thing that people struggle with. Then I would get the book and I would go straight to those arrhythmias, and I would be like, okay, well, I'm going to focus on ABNRT and AVRT, and I'm going to focus on what the differences are. If I was in a case today when I got home, I would go look up what I did.
Yeah.
And see if there was anything.
Do you remember seeing that?
Right. Did we look at this? Did we do this differential diagnosis? Did the map look, what did it look like? all those things. What catheter do we use? Oh, we use that one catheter. Oh, she has a step-by-step in here how to do that. Okay, Thermocool Smart Touch SF. Okay, yes, I've never used it before. We used it today. Then I would go here. Those people, I would go and review cases that I had done for the day, or cases.
I do feel like at the table it's more just plug this here, plug this here.
We gotta go.
Yeah.
Yeah, and then use
people are talking
this.
at you and around you, but not explaining.
Right, and then you use this either after the case is over, pull it out and go over it, or when you get home, sit down and read it and dissect it and be like, oh, the purpose of doing that was that it cools it and makes it more efficient, and then it prevents the char formation at the end. You know, oh, okay, well that makes sense.
Yeah, just
nobody's going to tell you that in the middle of the case. We're like, we need to go. So that's how I would use it between the two.
I think it's good, like as a debrief almost, or if you know you're going to use it ahead of time.
Oh yeah, if you have the heads up, we're going to use an Arctic front. I'd be like, okay. Let me just get this out right here. Because what I need to balloon prep, I need to do 50-50 contrast to saline, because we need to be able to see it. So why do we do that? We need to be able to see it. If you have the luxury of knowing what you're going to do, then yeah, you can read it in advance instead of on the back end, which would be even better.
Do you have a favorite case?
My favorite case, I love doing BT mapping.
Really?
Mapping BTs or PVCs.
They're both exciting. You know how to run the map. That's a unique feature.
Yeah. PVCs or VTs. VTs are a little more. PVCs are like.
Sounds like watching.
You got to sit and wait. You know, and then I started on Cardo XP. So. You literally had to watch the window of interest and wait for the PVC to go by, and I think it would capture 10 beats. Once you've froze a beat, I think it would capture 10. And so you'd be like, please, please, please let me,
Oh, yeah. So you're hoping it's in that window of when it happened. Yeah.
Yeah. Cardo XP was my favorite. I really struggled with, when Cardo 3 came out, I was like, so, and now, there's all these, Affair
for full,
all the different ones
floralist stuff now.
Yeah. Monitoring them was pretty fun too, but I liked mapping them.
If I ever worked in an EP lab, I really hope someone would teach me how to map.
Yeah.
I think that's what
And that's the last step.
Yeah.
Mapping is the last step.
As a student, that's what I spent most of my time asking questions about, is sitting with the rep and they walk through it with me, but then never being able to practice it. But that was always what interested me the most.
Yeah.
But maybe because they're the ones who taught me the most, and therefore it was the most interesting thing.
Probably, because you've got to understand what's going on the monitor in order to be able to map.
Yeah.
Because you got to be able to recognize morphologies, and is it the same morphology if it's a PVC? Because if you put the wrong morphology PVC in your map, your whole map's ruined. If it's the wrong cycle length and you put it in your map, it's ruined. Very tedious.
You have to know what you're doing.
So you have to know what you're doing, monitor perspective to follow over into the map. So typically, if you're a nurse, they put you as circulating first. If you're not a nurse and you're OJT in it, they're going to put you to scrub first, and then they move you from scrub to monitor, and then monitor to map. That's the most typical order. Some places may do it different, but
I think that's helpful, because then as a scrub person, after everything's in, you can pay attention but not really be expected to do anything, and just observe and intake and hear what's going on.
And a big difference in EP is that we don't say scrubbed in the entire case like you do in cath.
You do break them.
So a lot of times, if it's just if we're just starting out and we're doing the basic EP study, if in my world, if we were done, we broke scrub, and then the EP would do everything by himself when he got there.
Yeah, that's in clinical, that's what they had me do. I remember being like, are you sure?
Yeah.
I'll just sit here, just bring me a chair, I'll sit.
Yeah, EPs are way more self-sufficient than cath doctors are. And then of course, for AFibs and any kind of transeptal procedures, we stayed scrubbed in until we were across and verified and all that. But then we would break, and typically that person would either come out and sit with the monitor person, and they would run the stimulator and or the RF generator or cryo generator, And the monitor person would literally just monitor and answer the phone and whatnot, and they would do that. If not, then this person would typically come and map.
That makes sense.
Yeah. And then the monitor person had to do the protocols and the RF generator and all that stuff, and then the other
Well, I mean,
person would-
actually, it's kind of nice then if you're learning and that happens, because if I was scrub and you did expect me to do stim, but the actual monitor person was newer and was like, hey, can I do that? They can, and you're there with them. Versus cath, the scrub person's scrub, they can't come help you. And they're not seeing everything that you're seeing. So I feel like that's actually really nice to be able to speak up and be like, hey, do you mind if I do that? Or even if you just do this certain part because you haven't done that before, or the protocol that you did before didn't need that, so you hadn't done it. I think that's kind of nice. And to have a friend next to you to be like, yeah, that's right. Or no, change that.
Yeah, don't do that.
Yeah, don't do that.
Don't hit that button.
Thank you for your time. I'm so proud of you. I know this is well outside of your comfort zone. If you have any questions, please message Shawna on Instagram at Don't Miss the Hiss. We are on Facebook, TikTok, and Pinterest, and now YouTube, but she is mainly on Instagram because we're learning one platform at a time. And I'm just cross-posting to other platforms. So if you ask me anything on any other socials, I do try to direct you there. I had a few people message me on TikTok, and I'm like, hey, go on Instagram because she'll answer. Or I will pass along your question. You are also welcome to put questions in the comments because I will have her answer those as well. I just type them for her. And of course, like and subscribe. And we do cath education on Don't Miss a Beat. That is our sister company. Thank you. Bye.